Hey podcast listeners, Jim Siegler here. I know I'm not alone in saying how glad I am that 2020 has come to an end. We've been through a lot together with this whole coronavirus pandemic. And for me, it's been an incredibly eye-opening learning experience. A lot of sad memories. But a lot of good has come out of this as well. There's a lot that we've learned together over these 12 months. And today, we're going to feature 3 of our top programs from 2020. So without further ado, let me introduce myself from an episode on BrainWaves. Well, about BrainWaves. Walking around the hospital ER with a cold nowadays is like walking around ancient Babylon with leprosy. I coughed behind 2 layers of face masks and a face shield the other day, and a patient in the corridor gave me a look like I had grabbed the last roll of toilet paper off the shelf at the supermarket back in April. "Someone needs to get tested for COVID," she said. "But it's just a cold. I've been tested. It's not COVID. But I can't tell everyone that when I let out a sneeze or my speech comes off congested." People with epilepsy, many of them feel the same kind of stigma, as Toy Robinson and I discussed back in episode 65, Active Recovery. They feel like they don't belong, like they're diseased, and they shouldn't even associate themselves with civilized society. And for 1% of the American population who have a seizure disorder, that can be a real burden to bear. Anyway, I'm just rambling about me and this cold. Today we're not talking about the social stigma of epilepsy. We're talking about one of the tools that we use every day to make the diagnosis and to plan medical decision making. The EEG is one of the oldest and still most clinically useful assessments of neurophysiology.
An EEG, or an electroencephalogram, is sort of the foundation and actually a very, very good test.
Because it may register occasional split-second surges in the brainwave activity.
Surges, meaning synchronized cortical activity.
That is black and white.
Doctors call sharp waves,
which are irrefutable evidence of abnormal neuronal activity.
And that EEG really can pinpoint the particulars of the seizures.
And other than seizure activity, the EEG can also give you rich information regarding brain physiology in real time.
Frequency and amplitude.
Morphology, evolution over time, and with a reasonably good degree of spatial resolution.
And so I like that concrete feature that EEG gives me as a tool to take care of people who have epilepsy.
This week on BrainWaves, a podcast about neurology and medicine, and all the fascinating science and history that come with it, I'm talking with Dr. Tracy Milligan, an expert in the routine EEG.
I'm an epileptologist and neurologist at Brigham and Women's Hospital, and I'm vice chair for education for the Department of Neurology.
Dr. Milligan and I actually met almost a decade ago when I was still trying to figure out what kind of neurology I wanted to practice.
I always found disorders of the cerebral cortex really interesting, but epilepsy is the one where you can talk to people when they're functioning normally about how it was when they weren't functioning normally.
In our program today, Dr. Milligan and I will be discussing all the advantages and the limitations of this neurophysiologic test, when to do it, when not to do it, and how to apply the information you learn from it.
And that's really interesting.
Don't go anywhere. When I think about the utility of EEG, it does remind me a lot about the head CT. You mentioned it kind of being a black and white test. I don't know that it's so easy for me to know that something is certainly wrong or something is certainly fine. Usually I kind of do this test as a complement of a lot of other testing, either with my history or with my physical exam. What are your thoughts about the routine EEG in an average person?
Yeah, I think that what you said really resonates a lot, that it's used as a complement. So you really need to always start with the history, because just looking at an EEG without the history, we do that when we're interpreting EEGs. We don't want to know the history. We want to be as objective as possible. But to get an EEG, you really want to start with your history and have on your differential something where EEG would be helpful to you.
Other than for the diagnosis of epilepsy, for which a routine video EEG may only be 15 to 20% sensitive at predicting seizure recurrence.
It can be very specific, though.
A routine video EEG can also be useful for classifying specific events. Is this arm shaking or confusional spell a seizure, or is it non-epileptic? The EEG may also be useful for seizure localization and pre-surgical planning. Is it a temporal lobe epilepsy that could potentially be treated with surgical resection? Or is it a primary generalized epilepsy disorder that may be best managed with vagal nerve stimulation?
So when I'm ordering EEGs for my patients in clinic, it's a common thing that I tell them is the EEG will only help us if it's abnormal. And I think that's really important for our patients to know, as well as to keep in mind ourselves, because most of the time the patient is going into a test really hoping that it's normal. But when you don't have a diagnosis for a patient, a normal test is not helpful, and especially one with low sensitivity like EEG. So if it's abnormal, it's very, very helpful. If it's normal, it hasn't really helped us further along in determining the diagnosis.
EEGs come in several flavors, as I'm sure you know. The most commonly ordered EEG is a routine scalp recording,
EEG from anywhere from 20 to 40 minutes.
Which has the lowest sensitivity, but it's inexpensive, it's non-invasive, and we can get a lot of information about the interictal brain.
And the technologist will have the patient rest with their eyes closed and do different procedures, such as looking at reactivity, having them close their eyes, open their eyes, looking for a certain pattern that's normal on EEG. And then we also try during a routine EEG for 3 activation procedures. And those 3 activation procedures help us find abnormalities if abnormalities exist. And those 3 activation procedures are hyperventilation, typically for 3 minutes,
which can trigger seizure events in patients with absence epilepsy syndromes, but it may also induce epileptiform discharges in patients with partial seizures. Then we have
photic stimulation with flashing lights at different frequencies,
which triggers seizures in roughly 5% of patients with the photosensitive epilepsy syndromes like JME and Dravet syndrome,
and sleep,
which we try to achieve in all patients undergoing a routine EEG.
Because I do find that sleep is more sensitive for bringing out abnormalities.
Sleep and the transition into sleep is thought to be epileptogenic because the brain is switching between states of consciousness and the neuronal activity may become more rhythmic.
So that's a really important part of a routine EEG. Not everybody falls asleep during the EEG, but we do our best to capture sleep.
But, like outpatient cardiac event monitoring for paroxysmal AFib,
something that is a little more cumbersome.
The longer you monitor with EEG, the more likely you are to find an electrographic abnormality.
Ambulatory EEG is an EEG, sort of our version in neurology of the Holter monitor for the heart,
where there are other advantages besides just having a higher probability of capturing events.
The patient goes home for 24 to 72 hours. We record the EEG during that time, or maybe we want to see how frequent the seizures might be occurring in a typical day.
Because maybe the patient only experiences events at home under certain circumstances, which can't be replicated in the artificial environment of the neurology clinic.
Those would all be common reasons that we would order an EEG. And if we're looking for the diagnosis, then we start with a routine EEG, because I do find that sleep is more sensitive for bringing out abnormalities.
Or maybe you want to determine if the patient's showing an electrographic response to a new treatment or an intervention. And if the patient's undergoing pre-surgical evaluation and the seizure focus lies within eloquent cortex that's responsible for language, for example, the patient may undergo intracranial EEG, where electrodes are placed along the cortical surface or deep inside parenchymal tissue, depth electrodes. Next, Dr. Milligan and I spoke about the ideal circumstances in which a routine or a continuous EEG might be beneficial. Sleep depriving a patient may be one way to optimize the sensitivity for detecting something abnormal in an EEG. What other periods would be optimal for you to acquire a routine EEG or a longer-term study?
So if a routine EEG is normal and we're still trying to understand what the patient is experiencing, these transient events that they're experiencing, then the sooner that we can do the EEG after the event, the better.
I'll reiterate that. The sooner after a patient has had a clinical event, the higher the yield of the EEG. It's thought that, following the seizure, the brain is in a relative state of hyperexcitability. However, the evidence supporting this hypothesis is confounded by significant selection bias in observational studies. In general, there seems to be a trend towards a higher sensitivity of the routine EEG performed within 24 hours when compared to EEGs that are performed more than 72 hours later. That said, you can imagine that patients who are presumed to be at higher risk of recurrent seizures, maybe they have a structural brain lesion or they have a family history of epilepsy, the providers for those patients might be more aggressive in obtaining earlier EEGs, artificially inflating the positive findings in those patients who get EEG'd within 24 hours.
So the ability for people to more easily put on an EEG is something that is really important. It's important in the United States, where we're trying to think about ways to limit exposure to potential infections like COVID-19. And it's important worldwide, where there often isn't the availability of an EEG technologist. So I think that
Dr. Milligan mentions this because there are newer technologies that are emerging which can help us to detect seizure events or collect electrographic data, which can be used to predict seizure recurrence earlier after a patient has experienced a possible seizure.
As far as easy ways to put electrodes on the scalp, there are EEG caps that people have used, where you just sort of tightly put it down and it has electrode contacts. There are devices like StatNet, where there's big stickers that you put on.
At Mass General Brigham, Dr. Milligan recounts that sometimes they'll get a simple, quick result. Is the patient seizing or not?
And then what we've done historically in our hospital is below the hairline EEG. And that involves taking the stickers for EKG and just putting them, a series of them, under the hairline, and then plugging it into the EEG machine. So it's good for patients who are comatose and you want to make sure they're not in status epilepticus.
Yeah.
Because that would show up with just the below the hairline.
Kind of like a point-of-care glucose. You can imagine that it's a point-of-care brainwave test. And this technology can quickly and effectively simplify cerebral activity, or even become integrated into a patient's critical care, just like a vital sign.
Similar to what anesthesiologists do in the OR, where they're given a number for level of sedation using EEG, we can be given colors and numbers, and intensive care physicians can monitor EEG to look at perfusion, cerebral pressure, overall level of consciousness. And so it's one of those technologies.
Among the many benefits of EEG, I would also add that a routine EEG can be useful in a patient who has an undifferentiated encephalopathy. In the hospital, I often find myself ordering routine studies in patients with toxic or metabolic encephalopathies who fail to improve despite attempts at treating the proximal cause, treating an infection or something. You can feel validated when there's generalized slowing, triphasic waveforms, frontal intermittent rhythmic delta activity or excess beta, and no seizures when your patient remains altered and you presume that it's a metabolic encephalopathy. And there are other times when an EEG can be used to capture specific events and determine if they are seizures or not.
Because if I am on an EEG and having my typical event, which is strong sense of deja vu, depersonalization, out-of-body experience, and I'm telling you about it, the vast majority of the time it won't show up on EEG when it's a seizure. When it's that type of seizure, focal aware seizure, that's an internal event, even hallucinations, for example, the sensitivity of the EEG is only about 18%. Now, if I'm totally confused, staring off into space and not answering you, the EEG will be abnormal if it's a seizure.
This is because there is global cerebral dysfunction with complex partial seizures, or seizures which can affect awareness. Tiny hand twitching, or epilepsia partialis continua, you might see nothing.
The more of the motor cortex that's involved, the greater the sensitivity, even when the patient is aware.
Drop attack, generalized convulsions, those you should see on EEG if they are the result of an electrographic brain disturbance.
Somebody is totally out of it, not responsive, and the EEG does not show seizure activity, it's not a seizure happening then.
But as soon as you see those characteristic changes in amplitude,
Frequency,
morphology,
that is black and white,
and you see that they may have a field to them, or they may spread to other adjacent areas, then you know it's real. And other than trialing the patient on various antiepileptics, the EEG may be useful for other treatment modalities. In some instances, such as the pre-surgical planning for drug-resistant epilepsy, the routine EEG can be helpful for localizing the seizure focus. Like you said, is it generalized or is it focal? Would the patient benefit from temporal-lobe resection or something else? But even then, the routine EEG may still have some limitations. what are we missing with a routine EEG, and when might we want something more invasive?
Yeah, so I think just to step back, the utility of EEG in somebody you know has epilepsy, for every patient you have who has epilepsy, they should have an EEG at least once. That really guides your management, AED selection, even prognosis. For the patients who are drug resistant, and we're thinking about ways that surgery might be helpful, I would say for any patient who is drug resistant, they should be admitted to an epilepsy monitoring unit, because we want to make sure, first of all, we have the diagnosis correct, and then second of all, that we understand more about the seizures by actually recording the seizures. And just as a quick aside, one of the patients that I saw had a diagnosis of generalized epilepsy and continued seizures. The medications were not working. His EEG looked like somebody who had generalized epilepsy. But when we brought him in for monitoring, he had frontal lobe epilepsy and was a surgical candidate. So again, it's one of those situations you need to be the clinical in conjunction with the EEG. And sometimes to get your best clinical data, you actually have to see it for yourself and record the seizure. So in drug-resistant epilepsy, when we're considering surgery, we want to, first of all, by history, understand all of the seizure types a person is having, and then on EEG monitoring, capture those seizures by, often it means taking away medications so we can better record the seizures. Sometimes everything lines up. The patient has symptoms of temporal lobe epilepsy, the MRI is abnormal in one temporal lobe, and the surface EEG shows all the typical seizures come from the temporal lobe. Everything is concordant, and we can offer that patient surgery.
Which may help 60% of patients achieve seizure freedom, according to the 2001 randomized clinical trial by Wiebe and colleagues, published in the New England Journal of Medicine.
Other times, maybe we can't even see where the seizure starts on the surface EEG. The patient is on the epilepsy monitoring unit, they press the event button, they feel their typical seizure, and we're looking at the EEG and we don't see anything.
Because, it turns out, we need 3 square centimeters.
Several square centimeters of cerebral cortex
Of abnormally firing neurons.
That is on the surface, going through all of the meninges, the skull, and then through the scalp, and finally getting to the electrode. And sometimes that's it. And sometimes by the time we see something, all the electrodes are involved and we don't know where it started. So that would be a trickier circumstance where the surface EEG was not as helpful as we'd hoped it would be.
If the seizure doesn't occur or spread along cortical neurons directly beneath the skull, or if it occurs deep beneath the surface of the skull, a scalp EEG may not pick it up.
And at that point, we go to more invasive EEG recording.
Meaning intracranial monitoring, recordings from electrodes placed along the surface of the brain itself, or deep within the cortical tissue. For what it's worth, in the trial by Wiebe and colleagues that I mentioned before, involving the 80 patients with temporal lobe epilepsy who were randomized to temporal lobe surgery or to medical management, the majority of patients underwent pre-surgical planning with scalp EEG alone. Only 1 out of the 40 patients had a more individualized temporal lobectomy because of the findings on their intracranial EEG. So more often than not, invasive monitoring is not needed for surgical planning. Getting back to the yield of the scalp EEG, Dr. Milligan and I had mentioned how much brain tissue needs to be involved in order to detect an electrographic abnormality, and which part of the brain that's involved. You can imagine a focal motor seizure involving the leg may never be detected with a scalp recording, but there are other situations in which a scalp EEG may fail to give you the diagnosis.
So for example, frontal lobe epilepsy is notorious for being challenging to diagnose because, for example, hypermotor seizures, the patient may be moving around so much you're not even really getting a good surface EEG recording. And their seizures can look very unusual. Often they're making unusual motor movements with preservation of consciousness and or no postictal period.
And this can be very difficult to distinguish from a non-epileptic event, which can look like almost anything. But there are some classic findings on the video EEG during the recording.
The eyes are closed, head shaking side to side, epistatonus.
A lot of the times, the semiology of a non-epileptic event will change.
Asynchronous motor activity.
The arms and legs are shaking out of sync with each other.
Patient not responding.
Typically without any tongue biting, no incontinence of stool or urine, and no evidence of dysautonomia. Pupils are unchanged. Pulse is the same.
And on the EEG, you can actually see the electrodes and you don't see anything rhythmic, sharp, epileptiform, and you can see normal background activity. So that allows you to be sure that you've captured psychogenic non-epileptic events.
So, in conclusion, there is tremendous information you can glean from a routine interictal EEG.
I love EEG.
And it's useful whether the patient has epilepsy or not.
And it tells you so much about a person that no other test that exists tells you.
Does the patient have a predisposition for recurrent seizures? Where are the seizures coming from? Or is there something that's non-epileptic which could potentially explain the patient's neurologic dysfunction?
It has the highest temporal fidelity of any test. Right? We know at that exact millisecond what's happening.
It is a test almost entirely without risk.
Never harms a person. Our interpretation might, but putting the electrodes on the head for a routine EEG, it's safe, it's not expensive compared to our other diagnostic tests, and it gives us information that no other diagnostic test can give us.
I'm so sad that this is a podcast and no one can see how enthusiastic and passionate you are about this, Dr. Milligan. It's just, I want to go and look at EEGs right now.
Good.
I had a great time. Thank you so much for coming on.
Yeah. All right. Have a great day, Jim.
You too. Take care, Dr. Milligan. Bye-bye. Our next episode features a case presentation, a fictional account, of a young man who presented with an indolent but a concerning problem. We've talked about how you can approach weakness in several shows by now, considering disorders of muscle, the neuromuscular junction, peripheral nerve or plexus, root, cord, brainstem, all the way up to the pyramidal neurons of the primary motor cortex. Not only is it important to trace your steps through the nervous system, but it's also important to discern other patterns of symptoms that fit known neurologic conditions, sensory disturbances that affect the toes and the fingers, or the bilateral hands, cross findings with ipsilateral pain and temperature sensation loss to the face, with contralateral somatosensory loss in the body, or weakness that predominantly affects the forearms and the finger flexors. These descriptions should set off a few bells in your mind, and with time, hearing these complaints from your patients should help you quickly narrow your differential diagnosis. When I'm working in the hospital, a lot of medical conditions can cause generalized weakness. The patient may be critically ill and deconditioned, they could be anemic, depressed, hypoglycemic, over-medicated, or they may have multi-organ dysfunction. It's rarely a true organic neurological problem when we get asked to see a patient who has newly recognized weakness. In the outpatient world, it's a whole different ballgame, when the pattern of weakness isn't focal, as in weakness that be confined to a single extremity or a lateralizing side, and therefore it's not suggestive of a single peripheral nerve, root, spinal cord, or central nervous system lesion. You have to ask yourself, does it fit a pattern that's consistent with a disorder of the muscles, a myopathy, or of the neuromuscular junction? Or could it be multiple independent peripheral nerves? In this week's episode of BrainWaves, a podcast about neurology and medicine and all the fascinating science and history that come with it, we'll review the neurologic causes of proximal patterns of muscle weakness that you'll come across, and it's important to recognize them, or at least recognize when you should consider an EMG or a muscle biopsy, because even in the hospital, when you're treating somebody who has a COPD flare and the patient's also had progressive weakness walking upstairs, you could just chalk up her ambulatory difficulty to respiratory insufficiency. But it may be something else. Maybe her hip extensors could be weak because of an inflammatory polymyositis, which can be related to lung cancer and prior tobacco use. Knowing this information could absolutely change the way you manage these patients. And more on that in a minute. I'm Jim Sigler. Don't go anywhere. For today's topic, I thought we'd discuss a case. A 28-year-old construction worker was referred to the neurology clinic by his PCP because of a persistently elevated creatine kinase level that was initially attributed to statin use. He'd been prescribed a statin in his early 20s for a primary prevention purpose due to a family history of early heart disease and a routine cholesterol level in the 250s. Regarding the statin use, he had discontinued it more than 6 months earlier, and antibody testing against HMG-CoA reductase was negative. Still, his CK level continued to range from 3,000 to 9,000. In your clinic, the patient denied any constitutional symptoms, but he did endorse some thigh soreness that came and went regardless of the days in which he worked on construction sites. He also reported some minor difficulty while at work, and specifically, he had noticed that, compared to his coworkers, he was a little bit slower getting up the stairs, and he remembered being able to skip stairs in college, but has since been climbing up one step at a time. He said that he could still lift things normally, he felt pretty strong otherwise, it was just the stairs. But it's not really a problem, he tells you. On his physical exam, he was pretty built. 220 pounds, fair amount of muscle, no particular loss of bulk in any region. His mental status and cranial nerves were intact and normal, the power in his arms and hands were normal, but you could break his hamstrings and his quadriceps. Also, in spite of his muscular calves, he had difficulty standing on the balls of his feet, 1 foot at a time. Reflexes and sensation were normal, and movements were well coordinated. You ask him more questions about his family history, and he reports that his mother was diagnosed with multiple sclerosis in her 40s because of some difficulties ambulating, and eventually she developed joint stiffness and contractures. She required a wheelchair within 2 years of her diagnosis. At that time, no MRIs were performed, and she was only treated with an interferon. She eventually died of a pneumonia in her 50s. The patient reports no other medication use. He smoked cigarettes in college, but not any longer, and he drinks beer on the weekends, maybe 4 or 5 beers at most in a night. No illicit substances, and no other relevant medical history or review of systems. So let's think about this case for a minute. I've already primed you to look at the case through the lens of a myopathy, so how would you characterize this pattern of muscle disease? Problems with stairs are suggestive of a proximal weakness pattern. Gluteus and biceps femoris muscles, inferior gluteal nerve, superior gluteal nerve, sciatic nerve, and L5 and S1 nerve roots. But he also has trouble standing on his toes, which involves the gastrocnemius, tibial nerve, S1 root. Hard to imagine that he could have an L5 radiculopathy without any weakness of dorsiflexion, and it might be unusual to get a bilateral S1 radiculopathy. You might explain his symptoms to a disorder of the neuromuscular junction, something like a Lambert-Eaton myasthenic syndrome, which can present with proximal lower extremity weakness, but most patients with LIMS are over the age of 40 or 50, and they have an underlying cancer. A spinal cord lesion is possible, and the maternal history of multiple sclerosis is interesting, but I always force myself to doubt history of stroke or of multiple sclerosis in family members before MRIs became available. Maybe the patient's mother didn't have multiple sclerosis after all. Maybe she had something similar to what he has, and the condition could be heritable. What about a compressive cord lesion, like a canal stenosis? It's possible, but I might expect more back pain or spasticity and hyperreflexia on exam, just as I would with any other chronic central nervous system lesion. A disorder of the muscles in this case seems much more likely. When thinking about these disorders of muscle groups, if it's not a focal process, I think it's a useful exercise to characterize the prominent muscles that are affected. Is it a condition that purely affects the proximal muscles? Shoulders, biceps, triceps, hip and knee flexors and extensors. In a child, this would be a classic pattern for Duchenne muscular dystrophy, and in an adult, you would consider some of the limb-girdle muscular dystrophies like sarcoglycanopathy and Fukutin-related peptide muscular dystrophy. Is the pattern of weakness one that predominantly affects the proximal legs, and it either spares or involves the arm muscles? This would be consistent with some of the limb-girdle myopathies like calpainopathies, or a proximal myotonic myopathy, aka myotonic dystrophy type 2. Is it a distal predominant myopathy, as you might see in dysferlinopathies, or myotonic dystrophy type 1? Does the weakness involve the proximal arms and the distal legs, kind of opposites, as you might see in fascioscapulohumeral dystrophy, FSHD? Or could it be that the distal arms and the proximal lower extremities are involved, as we see sometimes in myotonic dystrophy type 2 and some of the myofibrillary myopathies? So breaking down the pattern is important because it can be useful to narrow your differential, although it may still be inevitable that you recommend a muscle biopsy or genetic testing to confirm that suspicion you have.
Anyways, getting back to our patient, the 28-year-old who we believe to have some undifferentiated myopathy. The pattern of his weakness seems to predominantly involve the lower extremities, and it seems slowly progressive. There's also evidence of chronic muscle breakdown based on the elevated CK in the serum, and maybe even a hereditary component, possibly with cardiac manifestations. But we can hardly make a diagnosis based on this information and the unclear maternal history, so we need more testing. To confirm it's a myopathy, and it's not some atypical form of a peripheral nerve disease like a CIDP variant, and it's not some other condition like early ALS, we can get an EMG and a nerve conduction study. Now, this next tangent we're about to take is important, so listen closely. Unlike what you see on EMG in chronic motor nerve diseases, which show long-duration, high-amplitude motor unit action potentials, in a myopathy, you'll see early recruitment, short-duration, small-amplitude polyphasic motor unit action potentials, kind of like this. Let's break this down for a sec, because these findings are worth knowing even if you're not a neuromuscular specialist. First, the polyphasic action potentials. You see multiple motor units firing because the number of motor units, which indicate healthy firing motor nerves, does not change with loss of muscle fibers. Conversely, you might see a reduction of these motor units in a chronic neuropathy. Next, let's think about the action potential duration, the width of those waveforms that you see on the EMG. In a myopathy, the duration shortens because there's a loss of muscle fibers with each motor unit that fires. Instead of the motor nerves sprouting new branches and innervating multiple adjacent muscle fibers, as you'd see with loss of motor nerves in a neuropathy, which increases the duration of the action potential, the loss of muscle fibers in myopathies means that each motor unit involves fewer and smaller muscle fibers, creating a smaller amplitude and duration. And the recruitment pattern, which is early, or it's increased in muscle disease, means that in order for the patient to generate enough power from that muscle, there is an early and inappropriate firing of many motor units to generate a small amount of force. So to quickly recap, with loss of muscle fibers, but preservation of the motor nerve, the action potentials become smaller, there's an earlier recruitment of adjacent fibers in order to generate more power, the duration of the action potentials are shorter, and there is a nonspecific polyphasia, which, to be honest, you can see in nerve diseases as well. So our patient went for the EMG, and we found that the biceps femoris, the quadriceps, and the gastroc all showed signs of a chronic myopathy, small amplitude, short duration potentials with slightly increased recruitment. But we also saw similar changes of the deltoid on the left, and the left biceps brachii. At this point, we're certain that our young gentleman has a myopathy, and largely a proximal myopathy, involving predominantly the lower extremities, but also the upper extremities and the calf muscles. The differential here is very long, but if you break down the causes into major categories, you're less likely to miss something. So, in this table that I found, one of the papers you can find referenced in the show notes, the authors broke down the categories into 6 groups. Toxic causes of proximal myopathy, drugs like statins, fibrates, corticosteroids, and other toxins like alcohol. Then there are the endocrine and metabolic myopathies, which can be caused by hypothyroidism, parathyroid disorders, adrenal pituitary dysfunction. Then there are the idiopathic inflammatory myopathies, which predominantly affect the legs in older patients, things like polymyositis and dermatomyositis with the overlap with polymyositis and inclusion body myositis. Then there's malignancy, and certain cancers can cause a paraneoplastic phenomenon with a proximal myopathy. You have the hereditary and the congenital myopathies, which include the limb-girdle muscular dystrophies, FSHD, Becker's muscular dystrophy, proximal myotonic myopathy, glycogen and lipid storage disorders. The 5th category is infective myopathies, which can be related to HIV, influenza, hepatitis B and C. And then there are miscellaneous causes, things like sarcoidosis. So lots of things to think about. And for the sake of time, let's just say we excluded each of these toxic, endocrinologic, and infectious causes of myopathy. And in our patient, we referred him for a muscle biopsy to determine which kind of a heritable or congenital myopathy he might have. Now you might say, Jim, what is the point here? We know that he has myopathy. None of these heritable myopathic disorders have a known treatment. Why put the patient through the biopsy in the first place? Well, there are a couple of reasons you should refer the patient for a biopsy, and other reasons to refer for genetic counseling and to see a neuromuscular specialist at that point. First of all, there are a number of clinical trials that are underway which are presently investigating new therapeutics, things like gene therapy and other technologies for patients with these conditions. and I just don't know all of them, so a specialist would be good here.
We've done more gene therapy trials than any place in the world in muscle disease. We've had more success.
I think research at the Johns Hopkins Myositis Center poises us in a very unique position.
We have been very involved with a number of different studies, first trying to understand the different forms of myositis.
We're currently running a phase 2 trial with...
From that, we're trying to develop new treatments.
Without that disease. These are the kinds of questions that we're trying to answer because...
This type of interaction is imperative for patient care. Brings back from the lab bench directly to the clinic what we learn every day.
Second, a muscle biopsy could provide the patient with a sense of closure, an answer to that question of, what is wrong with me? Third, there is invaluable prognostic information that comes with the histopathologic diagnosis. Somebody who has adult onset Pompe's disease, as we discussed in episode 150, may have a relatively mild course of their illness, and they can be treated with enzyme replacement therapy if the diagnosis is known, whereas somebody who has a sarcoglycanopathy may have a 40% chance of developing significant heart failure, will inevitably require positive pressure ventilation for respiratory support, and they have an average survival to about age 50 and no known treatment. Fourth, and lastly, family planning. What should the patient and their partner be thinking about? The most highly prevalent of the limb-girdle musculodystrophies, calpainopathy, is most commonly transmitted via an autosomal recessive pattern of inheritance, and it's very slowly progressive, with onset in the first or second decade of life. But in the autosomal dominant form of calpainopathy, disease onset occurs later in life. It's milder and even more slowly progressive. Honestly, I can't even keep track of all the different limb-girdle musculodystrophies, and you should refer to the published articles that we reference in this week's show notes for the summary tables classifying each type. But getting back to our patient, the 28-year-old construction worker, he goes for the muscle biopsy. The preliminary results are called back to you, and there are perivascular inflammatory cells concerning for polymyositis. But also, one of the sarcolemmal proteins of the muscle membrane, the dysferlin protein, is wholly absent. So now you're left with the question, is this an autoimmune myositis, or could this still be a heritable limb-girdle myopathy? The absence of dysferlin is highly suggestive of a dysferlinopathy, but you can also see loss of this protein in other limb-girdle musculodystrophies, like a calpainopathy, again, which is the most common of the limb-girdle diseases. But dysferlin should not be completely absent from the tissue on immunostaining, nor should it fail to show up on Western blot unless there is a true dysferlinopathy. Then again, there were also inflammatory cells in the perivascular space on the muscle biopsy, which could suggest a polymyositis. The serum CK is also consistent with an inflammatory myopathy, so we shouldn't just ignore this. However, polymyositis peaks in incidence in a patient's 60s, not at age 28. Even so, for this case, it would not be unreasonable to empirically treat with corticosteroids for a presumed idiopathic inflammatory myositis while you test for antibodies and for the genes that are responsible for dysferlinopathies. So you send off the ANA, the anti-Rho, anti-La, anti-Smith, ribonucleic protein, SCL70, although the patient has no other autoimmune manifestations. You send off anti-SRP and anti-Jo1, although he has no pulmonary manifestations. Maybe it is just early onset disease for polymyositis. And you send off your center's limb-girdle musculodystrophy panel, including the genetic test for the dysferlin gene, DYSF. 2 weeks pass, and you get your answer. The gentleman has a dysferlinopathy. And his case would not be atypical for any of the dysferlinopathies, which happens to be the second most common protein deficiency among the limb-girdle myopathies. The autosomal recessive dysferlinopathy predominantly affects the lower extremities, with either proximal, distal, or both proximal and distal involvement, as in our patient. Most patients come to clinical attention in their second or third decade of life, although it can present at any age. Luckily for our patient, cardiac involvement is extremely rare, and respiratory impairment is also much less of a concern for dysferlinopathies than with other myopathies. All things considered, probably one of the milder causes of muscle weakness, and one in which he does not need to continue taking corticosteroids for. That's for certain. Historically, we had thought that there may be an inflammatory component to dysferlinopathies because the immunostaining of muscle biopsies in dysferlinopathies shows inflammatory infiltrates, But a double-blind, placebo-controlled crossover trial of the corticosteroid deflazacort was conducted in 25 patients who had this condition. Perhaps surprisingly, or maybe not unsurprisingly, the use of steroids was associated with worsening power during the study period. It was not effective. So we still have no treatment for dysferlinopathies. For your patient, however, you are able to give him the news, counsel him on what to expect with the disease course, and reassure him that newer drugs are being explored every day. Gene therapy may be a part of his future. Presently, a phase 1 trial using an adenoviral vector is being conducted to determine whether gene transfer is safe in patients with dysferlinopathies. So many things for him to look forward to in the future.
What good is a neurology-themed podcast by a vascular neurologist without some vascular neurology? For this next and final segment of our 2020 collection, we probably introduced some level of hysteria among the middle-aged and the older listeners in the audience. Back pain, generalized leg weakness, and especially among men, urinary retention. These are common symptoms, etiologically non-specific. But sometimes, rarely, this constellation of complaints may comprise a more concerning narrative.
I think it's important to know that anybody in this game has missed a spinal dural AV fistula. What makes it so complicated from your standpoint is that it's almost always compounded by some element of degenerative spinal disease.
This is Dr. Brian Jankowitz, an associate professor of neurosurgery and the director of the cerebrovascular neurosurgery program at Cooper University Hospital.
I think most of us tend to have too high a threshold for performing a spinal diagnostic angiogram.
And hopefully, by the end of our program today, you'll appreciate the technical challenges and the advantages of a good spinal angiogram in a patient with a suspected spinal dural AV fistula.
Any spinal dural AV fistula that is diagnosed should be treated.
And we can only hope that your threshold for ordering a spinal angiogram will be much lower.
If this podcast does nothing more than puts spinal dural AV fistula on the differential of every neurologist, then we have done justice to society.
More on this in a minute. I'm Jim Siegler for BrainWaves. Stay with us. For our program this week, Dr. Jankowitz joined me in the studio to discuss his experience with spinal dural AV fistulas, to review the neuroimaging and management strategies, and so on. If you've never heard him speak before, he's the kind of neurosurgeon who will rattle off 6 reasons why that aneurysm should be clipped, or that one should be coiled. Or he'll ask you for at least 3 other conditions in your differential. One of the brightest guys that I know.
Do you need notes or anything? Are you good?
I don't think so. I mean, if you can tell.
But also hysterical.
Do you have any linguistic mantras that you say before you get on mic?
No, like how now, brown cow.
Methodist, Episcopalian.
First question I had is if you would mind just reminding us how the spinal cord is perfused.
Perhaps the most difficult question of the day. I have always found perfusion to the spinal cord to be much more intricate and complicated than the brain, simply because it's on a much smaller microscopic level that makes it difficult to visualize, therefore difficult to understand. In simplistic terms, you have 3 arteries running down the longitudinal axis of the spinal cord. The anterior spinal artery, which is derived from the 2 vertebral arteries, and the posterior spinal artery, which is actually also derived from either the 2 vertebral arteries or the bilateral posterior inferior cerebellar arteries. These 2 arteries run down the length of the spinal cord, giving off branches at each spinal level, which ultimately are called the segmental spinal arteries or the radiculomedullary arteries. And these arteries at each segmental level perfuse the spinal cord, but they're all interconnected. And they're of varying size, and they're of varying presence in the fact that some levels are devoid of these segmental arteries, and at some levels they're greatly enlarged. For instance, there is the artery of Adamkiewicz.
My whole medical career, I can't believe I've been saying it wrong.
Being in the low thoracic region, typically on the left from T8 to T12.
Which is anatomically important because that also happens to be where there's a less dense anastomotic network in that lower thoracic level. And again, that's the artery of
Adamkiewicz. My medical school neuroanatomy teacher would be incredibly proud that I pronounced it appropriately. Dr. Carson Schneck, who actually runs the neuroanatomy lab at Temple University, would be so happy to hear this. So more importantly than where the blood vessels come from, I think it's that it's a rich anastomotic network of interconnected vessels running up and down the spinal cord from stem to stern.
So what is a dural AV fistula? How do they form? And why are they so problematic? Dr. Jankowitz and I talked about this next.
Much like the vascular perfusion of the spinal cord, I think that AV fistulas are the most misunderstood, misdiagnosed, and confusing of the major vascular anomalies, thinking about aneurysms, AVMs, capillary telangiectasias, DVAs, and cavernous malformations. Once again, I think because we truly don't understand why they form or when they form, and they tend to evolve on a microscopic level that makes imaging incredibly difficult. To the best of our knowledge, we're not born with them, so we don't think they're congenital lesions, but by and large, dural AV fistulas arise from a traumatic event that incites neovascularization or possibly inflammation from either an infection or the sequelae of trauma.
You know, it's interesting, the theoretical relationship between a spinal dural AV fistula and trauma, as Dr. Jankowitz mentioned. I mean, how many older adults injure their back?
What are you doing? I'm stuck. I laid down, my back went out.
Oh, well, don't you worry. We're going to get you out of here.
Grab on. You know, Phil, this might not be the best.
No. I'm just going to rock you.
You're not going to necessarily chase down a dural AV fistula because of that, are you? You need a better clinical story.
Wait, why don't you just get someone who works
No,
here?
this is going to work. And... Oh, wow.
Spasming. No.
And the features of a spinal dural AV fistula are so heterogeneous that there's just no way to recognize it unless you're looking for it. I mean, how many patients feel weak in their legs following a back injury? How many older males have difficulty with urinary retention? Often because it's related to prostate enlargement. And yet, these are the symptoms that we see with dural fistulas.
It shouldn't be surprising that one of the most common cases that is brought to court regarding a neurosurgeon is the care and specifically the misdiagnosis of a spinal dural AV fistula. In fact, just last week, I provided expert testimony for a missed spinal dural AV fistula. And there aren't many diseases that have a whole body of literature just simply describing how often or easy it is to miss the diagnosis. As a neurosurgeon, I'm completely biased by the fact that I tend to get involved only after there is a very high suspicion or after it's already been diagnosed.
To jump in here again, in that same vein, neurosurgeons like Dr. Jankowitz have this bias where a fistula is highly suspected, and it's up to surgeons like Dr. Jankowitz to hunt it down. But also, neurosurgeons take referrals for degenerative disc disease and back pain, a far greater number of these than rule out dural AV fistula. So while they may have that advantage sometimes of knowing that, okay, I need to find the fistula, I do feel bad for them because they're our last line of defense, so to speak. And if they don't see it, the disease will progress.
I feel for the doctors that have to live on the front lines diagnosing this disease because it can present with nothing more than insidious back pain. But this is where you have to use your spidey sense as a physician.
Before we get ahead of ourselves, again, a spinal dural AV fistula is very rare. Population-based studies estimate the annualized incidence rate to be about 5 to 10 per million people per year. Granted, that's probably an underestimate because you have to be looking for it, and we often aren't. To heighten your spidey sense, as Dr. Jankowitz called it, you should be thinking about a dural AV fistula in your older male patients. Spinal dural fistula is 5 times more common in men than women, and the mean age of diagnosis is 55 to 60 years. And these patients have really poorly localizable symptoms. No real pain that drives a patient to seek medical attention.
Painless, slowly progressive loss of neurologic function.
Sometimes with patchy paresthesias of the lower extremities.
Profound hyposthesias.
Difficulty climbing stairs.
Progressive inability to walk without some clear underlying anatomic cause.
And later in the course of the disease, incontinence, erectile dysfunction, urinary retention.
Progressive loss of bowel and bladder function.
The patient could have lumbar disc disease, foraminal stenosis, osteoarthritis, or prostate enlargement.
Dissatisfying, huh? Because I'm pretty dissatisfied.
It is a very... And all these conditions are far more common than a spinal dural AV fistula. If you're not looking for it, you're going to miss it. Like if you're not looking for a venous sinus thrombosis, that's something else that I think about that you have to be looking for as a cause of an intracranial hemorrhage. Every time I see an intracranial hemorrhage, I'm always thinking, could this be a venous sinus thrombosis? With this situation, insidious lower back pain, maybe erectile dysfunction in an older person who could have some mild disc extrusion or some foraminal stenosis. How do I know that I need to chase this further and then send the patient to you?
The good news is, because de facto a spinal dural AV fistula has an arteriovenous shunt that typically pumps high pressure blood into a low flow system, veins, you usually see engorged veins on an MRI of the spinal canal.
And you probably ordered that MRI looking for those other conditions like canal stenosis, myelitis, or root disease.
Typically in the mid-thoracic region, it can extend as high as the cervical region and sometimes even be in the lumbar region. But particularly on a sagittal T2 of the spinal canal, cervical, thoracic, or the lumbar region, most of the time you're going to see dilated veins, if not a tangle of serpiginous veins extending along multiple levels of the spinal canal.
From at least one good case series out of UCSF, these T2 flow voids are more than 80% sensitive for the diagnosis of a dural AV fistula, and combined with the T2 hyperintense signal we see in the cord, which we see nonspecifically with edema, that sensitivity grows to 100% with a specificity of 97%.
The real problem is when there aren't engorged veins on the MRI. Fortunately, most of the time there are.
Again, you'll see them more than 80% of the time.
The only other way to ensure that you follow the path down the road of a dural AV fistula is insidious onset, no clear event that brought the symptoms on, and a progressive neurological decline far out of proportion than a typical degenerative spinal pathology. What makes it so complicated from your standpoint, once again on the front lines, is that it's almost always compounded by some element of degenerative spinal disease.
The patient may also have some pain, which could be related to the fistula. It's thought that some of these are induced by trauma, as we mentioned before, or the pain could simply be a red herring, completely irrelevant and coincidental.
It's remarkable how often that the pain, even minor in nature, completely unrelated, will bring that patient to a doctor's office when in fact they've had progressive neurologic decline or loss of function that is much more apparent to you and less apparent or concerning to the patient.
And let me jump in here and say that we've all got different thresholds of pain. Some patients may cry out for muscle relaxants and narcotics for the mildest degree of spinal canal stenosis, and some patients may have such profound radiculopathy with foot drop or hand weakness that the sensory afferent fibers are completely obliterated, and the patient may feel nothing at all. So I tend not to put much stock in pain or subjective symptoms. What does the muscle bulk look like? What are their reflexes?
I think most of us tend to have too high a threshold for performing a spinal diagnostic angiogram to rule out a spinal dural AV fistula. There's a stigma about spinal angiography, much like there was a stigma about cerebral angiography 20 years ago, where the reported complication rates were exceedingly high and certainly unrealistic compared to how safe they are today. So I perform perhaps 5 spinal diagnostic angiograms a year looking for dural AV fistulas, and the vast majority are positive. So the positive predictor.
The fact that the majority of angios that Dr. Jankowitz does to rule out a spinal dural AV fistula, the fact that most of these are positive, to Dr. Jankowitz, that indicates that we're probably not doing enough of them. There have to be many, many more cases of a dural AV fistula out there that we're missing. And there needs to be a lower threshold to consider a conventional angiogram, which is the gold standard for diagnosing the condition.
Yeah, if we just plant the seed in the brain of a neurologist to look for this and can keep it on the differential, then we will save innumerable lawsuits for neurosurgeons who have missed this diagnosis, because more often than not, I would say neurosurgeons are referred these patients to treat their pain. And once you go down that slippery slope of being given a pain-generating diagnosis from degenerative spinal disease, it's very hard to get that patient off that inevitable cascade towards pain management and surgery.
Anchoring bias. Yeah. All right, seed is planted. You suspect a spinal dural AV fistula on the basis of progressive neurologic worsening, deteriorating power in the legs or incontinence of urine, dysesthesias of the thighs, and the patient's primary care provider or orthopedist, or maybe their neurologist, they order an MRI of the lumbar spine, and there is no significant orthopedic pathology to explain the patient's symptoms. What next? For some patients, you might be ruling out a myelopathy, B12, folate deficiency, copper deficiency, HIV, maybe checking the cerebrospinal fluid for albuminocytologic dissociation, or you're going to get an EMG to rule out chronic inflammatory demyelinating polyneuropathy. Some patients may even warrant a brain MRI to look for a parafalcine mass, like a meningioma. And for some, when you're really starting to wonder, could this be a dural AV fistula? You'll want to get that angiogram.
First of all, a spinal angiogram is a significant endeavor. I think it's important to note it does require catheterizing every segmental artery from L4 on up to wherever the segmental arteries end, which is variable and somewhere around T4 to T7. That means bilaterally from at least T7 down to L4, you are injecting an artery with contrast and using radiation to see what's going on.
To give you a sense of the dose of the radiation, compared to a head CT angiogram, a conventional angiogram carries roughly 5 times more radiation. And if you think about the radiation needed for a carotid stent, the radiation needed to treat a vascular malformation of the spine is 7 times greater than that.
It is a tedious procedure that requires a lot of contrast and a surprising amount of radiation. That's one of the reasons why you might find us somewhat reticent to jump into a spinal angiogram. After the diagnosis has been made, the decision always revolves around one of 3 treatment modalities: endovascular embolization,
by far the least invasive modality,
radiosurgery,
using gamma knife.
I should comment that spinal radiosurgery is still somewhat in its infancy.
Not ready for prime time for most patients. And then our last treatment option for a spinal dural AV fistula, which is thought to be curative, would be
open surgery,
which Dr. Jankowitz informed me can be very minimally invasive for some patients, i.e. those with a small dorsal dural AV fistula, or it can be quite invasive.
Currently, I'd say that the vast majority of lesions are treated with endovascular means, usually using a liquid embolic agent to occlude the fistulous connection. Unfortunately, I'd say it fails in a significant number of cases.
According to some older observational data, endovascular embolization fails as often as 25% of the time.
And many patients ultimately require open surgery for curative therapy.
The reason for failure of embolization is complex, and not only is every patient different, but we really lack randomized trial data, and we have poor spatial resolution of our current diagnostic neuroimaging to know really if these treatments are effective at the microvascular level, or if they may only be temporizing. What I mean by that is this. Dr. Jankowitz and others believe that the spinal dural AV fistula that you see radiographically on MRA or on the conventional angiogram, that's really just one head of the hydra.
And you may have seen this where repeated attempts at endovascular treatment has created a monster, has incited...
When you embolize what you see in that fistula, you're probably only embolizing the dominant component of the malformation. There are probably these microscopic vessels that we cannot even see.
What we don't see are all of the other microscopic or dormant, angiographically invisible feeders to the fistula.
And whether they're there or not, sometimes they come back with a vengeance, like the demon flytrap from The Little Shop of Horrors.
Eat me! Eat me!
The spinal perfusion is so rich and complicated that it is one of the few arterial systems that is nearly beyond our ability to discern, even with magnified angiography.
So you will miss much of that microscopic anastomotic network
that you cannot see and are nearly invisible to the human or angiographic eye. So I would say the complication rates for dural AV fistulas in the spine are much higher than intracranially.
For example, you could occlude an important arterial feeder to the spine, causing cord infarction, which does happen a small percent of the time, although sometimes it's hard to know in these patients. Or you may not occlude the correct vessel, and the patient develops a worsening myelopathy, which can happen 20 to 50% of the time, depending on which study you reference. because there is this resultant neovascularization, or recruitment of those microscopic feeding vessels that will ultimately regrow the fistulous network.
In the end, it sounds very simple. You simply need to disconnect the artery and the vein. You need to find the fistulous connection and infiltrate that connection with typically a liquid embolic. Although to lead to a long-term or durable cure, that liquid embolic needs to traverse the fistulous connection and enter into and occlude the draining vein. And only enough of that draining vein that is pathological, because parts of that draining vein can be draining normal spinal vasculature. So it's a very delicate balance.
You can imagine why it's so complicated, and why patients are often referred to major centers with highly specialized neurosurgeons for this type of procedure, especially if there happens to be an intraoperative complication of the endovascular approach.
Well, the good news is that falling back on open surgery is always a possibility. And it's rare that endovascular treatment in the acute setting makes things more difficult with open surgery.
In other words, embolization doesn't mean that you can't later proceed with an open surgical approach.
So if you fail to cure a spinal dural AV fistula with endovascular means, then I would quickly, and this is probably an important point, quickly transition to open surgery to avoid it recruiting further blood vessels and making it much more complicated. Because the vast majority of AV fistulas are fed by a single radiculomedullary artery that, if you know where it is anatomically, is relatively straightforward to knock out with surgery. But spinal dural AV fistulas come in two general flavors, those located dorsally and those located ventrally.
The dorsal fistulas being far more common and also being more accessible to treat with endovascular or surgical means.
Because they're dorsal, they typically are easily accessible by a simple laminectomy, typically one-level laminectomy, and they're easy to visualize and easy to treat with nothing more than a bipolar and a small amount of coagulation.
Then we have the ventral dural AV fistulas, which thankfully are less common, but unfortunately very difficult to reach.
Because they are surgically inaccessible and typically associated with feeding from the interspinal artery, which means that they're much higher risk if you happen to injure or coagulate the wrong feeding artery.
So you've made the diagnosis. Fortunately, you lowered your threshold to perform that spinal angiogram in your patient with an unknown cause of a myelopathy, and you found that dural AV fistula. What next?
I always follow up these patients in the long term. Unfortunately, primarily because their spinal cord pathology is so advanced that they need months to years to recover. And I want to ensure that they continue to make progress over time. And two, because they're notoriously hard to treat, there is a significant number of patients whose AV fistula recurs when in actuality it simply wasn't cured the first time, and there were anastomotic connections that weren't visualized that proliferate and reestablish the fistula.
Feed me!
All that means is I always perform a short-term and long-term catheter-based spinal angiogram to ensure that these remain dormant and eradicated. That being, I follow up a cured, at least theoretically, spinal dural AV fistula with a spinal angiogram at 3 months, and then a repeat spinal angiogram at minimum 9 to 12 months after that.
For most patients who achieve a durable cure, they tend to show slow and progressive improvement in their motor function during this period, which is reassuring to surgeons like Dr. Jankowitz. There's also typical interval improvement in the spinal cord edema as the venous congestion resolves. So some physicians will perform interval MRIs to check on this, but really the angiogram remains that gold standard for diagnosis and for follow-up. And would you agree with some of the literature that 2/3 of patients make good neurologic recoveries after their dural AV fistula has been managed? And then also, would you agree that some features or clinical exam findings tend to improve more so than others, like weakness or numbness or tingling, whereas incontinence and sphincter tone may not improve necessarily?
As usual, the rule of thirds applies. Even though most everybody will experience some element of functional recovery, still a third are left devastated. A third of patients are left not significantly better even after cure, and a third do fantastically well, particularly those diagnosed early and treated aggressively. It seems to me that motor function always improves to the point where patients usually can ambulate, albeit with assistance. Bowel and bladder function tends to lag behind, and I find often does not significantly recover and leaves many people with long-term, at least urinary incontinence. Sensory function is all over the place, and I don't find it predictive or consistent with regards to its recovery.
As we're wrapping up our program, I can't emphasize enough how low your threshold should be to perform a spinal angiogram or to refer a patient for one in any patient who has an unknown cause of a myelopathy, especially if they meet those other demographic factors. Dr. Jankowitz also had a good take-home message for you.
I think it's important to know that anybody in this game has missed a spinal dural AV fistula or been tricked by it masquerading as a C6-7 herniated disc. What's most important is that you keep it on the differential, that there is always time to put it back on the differential and refer for a spinal angiogram. I think it's also very important to find somebody that is comfortable diagnosing and treating this disease. Usually that is an interventional neuroradiologist or cerebrovascular neurosurgeon, to make sure that you have somebody that you can contact at a moment's notice and just run it by them, because there needs to be many more curbside consults regarding the possibility of this pathology being a spinal dural AV fistula. And we can't leave them on the table, because I think unlike many other pathologies and even some cranial dural AV fistulas, the natural history of this disease is inevitably towards profound loss of neurological function. And thus they should all be treated and they should all be diagnosed as soon as possible.
This week's episode of the BrainWaves podcast was produced by myself, Jim Siegler. Special thanks again to Drs. Tracy Milligan and Brian Jankowitz for their contributions to the earlier shows from this year. Today's program is produced out of Studio 3 in Philadelphia, Pennsylvania, with music courtesy of Jazar, Kevin MacLeod, Patches, Montplaisir, Steve Combs, Lee, Rosevere, Siddhartha, Soft and Furious, Magic in the Other, and Loyalty Freak Music. The opening theme of our show was composed by Jimothy Dalton. Sound effects by Mike Koenig and Daniel Simeone. For more information on what was discussed in the show, as always, you can take a look at the show notes for the references to the highest yield literature on the topics, and follow us on Twitter at BrainWaves Audio. I'm Jim Siegler, and I'll talk to you again in 2021.